Good evening. I'm Belva Davis, and welcome to This Week in Northern California. The Obama administration has made national health care reform a top priority in the face of vocal opposition. On November 7th, the House passed the Affordable Health Care for America Act by a vote of 220 to 215. Last Saturday night, a 2,000-page proposal was narrowly approved for debate on the Senate floor. But the 60 Democrats and independents who voted yes are still deeply divided over the details, primarily whether or not a public option will be included. Full-scale debate in the Senate begins Monday, November the 30th. Tonight, we talk with Congresswoman Eshoo, who is on the House Energy and Commerce Committee. Also joining me, Sarah Varney, reporter for KQED Public Radio. And from Sacramento, Anthony Wright, Director of Health Access, a consumer advocacy group. We turn to you, first of all, Congresswoman, to say now the House has a bill. The Senate has a bill to debate.
Finally.
Some are saying the bills are more than similar, that they're almost identical, almost to 90% of the bills. Would you agree with that or not?
Well, I think in looking at what the Senate has come up with, they're about 85%, I would say, so in the ballpark with one another. There are some differences. The Senate bill does not cover as many people, will not insure as many as the House does. It has a different way of paying for the costs of the bill. They are almost identical in terms of bringing down the deficit. They are identical in terms of the insurance reforms. But the Senate bill does not disallow the antitrust exemption as the House does. The House bill is, I think, more generous in terms of its subsidies in helping to make health insurance premiums affordable to people, which is a huge problem in the country. And we have what I would say is a far more robust public option than the Senate bill. The Senate bill allows states to opt out. And so those are some of the differences, but they'll be debated. And of course, in the Senate, unlike the House, senators can amend a bill on the floor. We can't do that. So sometimes there's a very close call in a committee, and it can turn out to be a completely different story on the floor of the Senate. So we'll all watch, and I'm thrilled that they came up with the 60 votes so that the bill can be debated. So a relative of mine, an elderly relative, reminded me that this is the closest we have come in the history of our country to reforming our health care system since President Teddy Roosevelt first took it on.
Why do you think that, just almost to a vote, that the Republicans are opposed to this bill?
Well, this is, I think it's ideological. The Republicans very sincerely do not think, they do not believe that the government should be involved in this. I asked the Librarian of Congress to lift some of the debate that took place from the congressional record during Social Security and during Medicare. And I was stunned when I read it, because the exact same debate took place then as is taking place now. I mean, the same things were said, and I wouldn't have believed it unless I'd read it myself, that this is government intervention, that we have big government in your life, that it was going to create the sky to cave in, that America simply would not be America anymore, that people would lose their freedom. It's stunning how almost exactly the same things are being said. So
it's helpful too to remember in 1963-64, about half of all seniors in this country didn't have health insurance.
That's right.
So imagine today if 50% of our elderly population was uninsured, what that would look like.
Yeah, and that those were the things that were being said to the contrary of that than during the Medicare debate. So I guess history is repeating itself in terms of what's been said, but I would say that it's really their view of the world, and I think they're sincere about it. I don't agree with them, obviously, because there's a huge, huge need in the country, and it's breaking the back of government, of businesses, of families. I mean, the majority of personal bankruptcies in the country, Belva, are due to health care costs.
What do you think are the most important elements that the House bill delivers that you hope the Senate will include?
Well, first of all, affordability. If premiums, health insurance premiums are not affordable, we can do all the talking we want about reform. People will not be able to access it because they won't be able to afford it. So the prices will come down. The public option is going to help do that because that'll create real competition. Many, many states, 30-some states, there may be only one or two providers in a state. Security, and that is that if you lose your job, I mean, here we are as Californians, 12.3% unemployment. So if you lose your job, you will not lose your health care. Seniors, we will fill what's called the donut hole that was created a handful of years ago. So the out-of-pocket huge costs for prescription drugs for seniors will be taken care of. And that's not the case in the Senate. They don't close the whole donut hole. So security, affordability, and it is, contrary to what my Republican friends say, the bill is fully paid for. In fact, it will help bring down the deficit. $139 billion over 10 years with the House bill, about $130 billion over 10 years with the Senate bill.
Well, we have also with us Anthony Wright, who's up in Sacramento, a group that's been advocating for better health care for all. So, Anthony, what do you think are the most important elements that both the Senate and the House have to come together on?
Well, I think it provides real security and stability for people who have coverage and expands coverage to those who don't in each of the ways that people get coverage through their employer, through a public program like Medicaid or Medicare, or if they buy coverage as an individual. For people who get employer-based coverage, which is about half of Californians, there would be a standard which employers would have to contribute to the health coverage of their workers. But at the same time, there would be new subsidies to small businesses to make sure that they could afford that coverage moving forward. For people who are on Medicaid, the program would be streamlined as well as expanded so that we would cover people under the poverty level, which was a commitment that we've never fulfilled in this country. And for Medicare, it would be improved. As the Congresswoman said, it would close that donut hole that leaves so many seniors without adequate prescription drug coverage. But the real benefits are in the individual market, where people right now are denied for pre-existing conditions, and if they do buy coverage, it's the most expensive, least efficient way to get coverage. And what it would do is set up a new exchange where people could better easily understand their benefits, get subsidies so it was no more than a certain percentage of their income, and also have the choice of not just private coverage, but a new public health insurance option, which would really get some competition in the marketplace and bring down costs. So these are real benefits for people, however you get coverage, making sure that there's more security for people who have it, but also expands it for those who don't.
Sarah, you've been covering this issue, asking people like the Congresswoman here about the elements of this bill that seem to be so much in controversy. What have you found to be the most helpful or contentious issues at this point of the debate?
Well, I just wanted to go off of something that Anthony said for just a second, because I think there are a lot of details in the bill that have not really come to light, in part because we spend so much time covering the political horse race. And I think it's actually very helpful, because as I've gone around the state for the last 7 years or so doing stories about healthcare and these stories of people who don't have health insurance, who lose their health insurance, I think it's really helpful for people to understand that these subsidies that Anthony referenced really do stretch into the middle class. So in both the Senate and the House bill, it's set up the exact same way. If you're not eligible for Medicaid, so you earn beyond the certain federal poverty level, you can get a government subsidy for up to 4 times the federal poverty level. So for a family of 4, that's about $88,000 a year. And in a high-cost state like California, I think the California congressional delegation would argue that's incredibly important. I've met so many people over the last year in particular who have lost their jobs, who didn't quite qualify for that COBRA subsidy. They didn't come in before the COBRA subsidy kicked in, and were earning $60,000, $70,000 a year and couldn't afford health insurance. So these government subsidies really are not just meant for the poor, but are really meant for the middle class as well.
What have you found has been the most sensitive issues that maybe could derail this process, if at all?
Well, I don't think there's one issue that will derail it, but I think that there are some major parts of the legislation that I hope the Senate will retain. Number one, the public option, because I think that that will bring about good old-fashioned competition. Secondly, as Sarah was just mentioning, the subsidies. The subsidies are very important. This isn't just about those that don't have health insurance, but those that simply cannot afford. Middle-class families cannot afford the premiums to go out into the private market and buy a policy. So those subsidies are very important. The issue of abortion, Belva, has raised its head. And for many, many years, as far back as I can remember in the House, almost as long as I've been there, the Hyde Amendment, the Hyde language has always prevailed. That's been on all the appropriation bills. But there's a conservative Democrat, Bart Stupak from Michigan, that has gone beyond that. And that amendment passed and was part of the House bill. So my hope is that what the Senate will do is to stick with the Hyde language. We can live with that.
The Hyde language did what?
The Hyde language does not allow any federal funds to be used to pay for abortions. And but the Stupak language goes far beyond that. For any policy that will be listed on the exchange, they will not be able to offer those services, even if a woman wants to pay for it out of her own pocket. So it does go beyond the Hyde language, and I think it's onerous for women, and I think it's the most onerous thing that's come down the pike, to tell you the truth, short of the Supreme Court reversing Roe v. Wade.
Sarah, is this a big issue as you've covered it here locally? Is there a message for the Congress and what you're hearing from people who'd be affected by this?
I've not reported myself on the abortion amendment. I've spent a lot of time looking right now at the physician payment reforms that are actually included in the legislation, which are quite significant. We've talked a lot about the problem of fee-for-service in this country, where physicians are paid per test, per procedure. They're paid a lot more for high touch than for just sitting down and talking with their patients. And much research of the Medicare data over the last 20 years suggests that this has really led to a sort of overprescribing of medical care in this country. So there are some things in both the Senate and the House bills which the Congressional Budget Office has scored favorably in terms of saving money over the next decade. The one that's the most interesting model from my perspective is what's called an accountable care organization, where essentially it's sort of a form of capitation. It's almost a form of HMO, but at the medical office level. And it can be on a variety of scales. It can go from just sort of rewards or incentives for physicians' offices that improve quality but also bring down costs. Or it can go at the other end to, you're a physician, you're a primary care physician, I give you set amount of money to take care of your patients for a month. And if you come in under cost, you get to keep the extra. And if you go over, well, you're stuck with the bill. And what we have seen, and I was just at a practice a couple weeks ago down in San Bernardino County that does this, and it's remarkable how that reorients the thinking in the office. Everybody's very focused on chronic disease management. Let's get those people who have diabetes into the office every month so we can really manage them. Let's talk to the hospitals so that the hospitals know that you're not going to earn any extra money by keeping these patients in for an extra day. In fact, we need to get them out to save some money. But of course, not before
I
the
want to
person's
ask
ready.
you, Congresswoman, about this issue, but I also want to bring Anthony in here because in California it's a big issue, and certainly there, and that is undocumented. Anthony, that's a big California issue, but it is across the country. How is that being dealt with? And as an advocacy group, do you think that there will be any chance that any coverage for this category of people?
The bills are in agreement that no federal funds should be used for the coverage of undocumented immigrants. Whether you think that's a good thing or not, that's the agreement between the House and the Senate proposals. Similar to the Stupak Amendment on abortion, the Senate goes one step further, I think, in terms of prohibiting undocumented immigrants from using their own money to purchase health coverage on this exchange. and it seems that that would be counterproductive. We want people to be covered, and if they're using their own money, I don't know why there would be an objection to that. I think that for Californians, what this would be is a benefit in general, because to the extent that this provides more funds for our public health safety net, for our public coverage programs, it will help bolster the health system that we all depend on, regardless of our status. And so it is, there are some differences there too. You know, it's hard to have a health care debate without touching on some of the hot button issues of our society.
Well, the one thing that critics have said, though, some on the, at least those on the progressive side, that insurance companies come out pretty good on this, that the Congress has not really cracked down on profits made by insurers.
Well, they should come to Washington and see all the people lined up lobbying against the bill, and then they'd know that the insurance companies don't like it very well. So I disagree with that description. But the insurance companies will be part of, at least under the House bill, competing not only with one another, but also with a public option. So the bill that we wrote does protect choice. So if you have what you like right now, no one is forced to drop that and not be able to see the doctor of their choice. So the insurers will continue to be in business. But many of the rules of the road of the private insurers are changing. No longer will pre-existing conditions be a reason for insurers to ban someone from being insured. Something that most people don't realize, and that is the fine print in their health insurance policy has a lifetime cap on how much they will ultimately pay. In the disabled community, they know this issue very well because they can hit the ceiling much faster and much earlier than the rest of us. And I'm really proud because it's a bill that I carried for over a decade. And so the House bill bans the lifetime cap limit, as well as rescissions, where if you get really sick, that they can just drop you. So I think that those are very, very strong insurance reforms. But yes, will they still be able to compete and stay in business? Yes, but with new rules.
I think one question that I've often wondered is when we were debating health reform here in California, we had this requirement that insurers had to spend at least 85 cents of every dollar on actual health care. And there was a lot of debate about what actually health care was.
Well, there will be a lot of debate, too, in the
we'll have
Senate
to come to that
starting next
another
Monday.
time.
So we'll have to come to that, and we'll hope that by the next Friday that we have a real bill. My thanks to all of you for joining us
Thank you very
tonight.
much.
Yes.